Hi, this talk will cover Alzheimer's disease, which is the most common form of dementia in the U.S. Classical Alzheimer disease clinical phenotype is characterized by decline from a previous level of function, interference in daily living, work, and social interaction, cognitive impairment with significant emphasis on episodic memory, accompanied by progressive and increasing involvement of other cognitive domains, visual spatial function, executive skills, attention, praxis, language, and progressive behavioral deterioration, including depressive symptoms, disruptive behavior, apathy, anxiety, and psychosis. The fundamental abnormality in AD is the accumulation of two proteins, A-beta and tau, in specific brain regions, likely as a result of excessive production and defective removal. The two pathologic hallmarks of AD, particularly evident in the end stages of the illness, are plaques and tangles. Plaques are deposits of aggregated A-beta peptides in the neuropile, while tangles are aggregates of the microtubule binding protein tau, which develop intracellularly and then persist extracellularly after neuronal death. Both plaques and tangles appear to contribute to neural dysfunction, and the interplay between the processes that lead to the accumulation of these abnormal aggregates is critically important in the pathogenesis of AD. Several lines of evidence strongly support a model in which A-beta generation is the critical initiating event for the development of AD. However, the pathogenesis of AD involves not only A-beta and tau, but several other intersecting genetic and host factors. A-beta peptides result from defective processing of the cell surface protein amyloid precursor protein, or APP. Once generated, however, A-beta peptides are highly prone to aggregation, eventually forming the recognizable large aggregates and fibrils. Tau protein is a microtubule-associated protein that's normally found in axons. With the development of tangles, the distribution is shifted to the body and dendrites of neurons and becomes hyperphosphorylated, losing its ability to bind to microtubules. However, the mechanism initiating this event is unknown. All we know is that we can identify these microscopically, particularly with immunohistochemical stains to tau protein. Moreover, we know that identifying these as part of tangles is associated with the pathology and clinical pathological syndrome of Alzheimer's disease. A decrease in brain weight is a usual but inconstant finding. It's not required for diagnosis. The most severe atrophy is found in early onset and familial types of Alzheimer's disease. Gyral atrophy and ventricular dilation are typically seen. The mesial temporal lobe structures, including the temporal cortex, amygdala, entorhinal cortex, and hippocampus, are most affected. The next most affected are the frontal and parietal lobes, with relative sparing of the occipital lobe. Lateral ventricular dilation is present and is often severe in the temporal horn. Note the cortical atrophy, which is most apparent over the parietal and frontal lobe, demonstrated by widened sulci and narrowed gyri. In this coronal section, note the gyral atrophy, especially in the temporal and parietal lobes, and enlarged ventricles, especially in the temporal horns. Next, I'll talk about the histological hallmarks of Alzheimer's disease. First is neuritic plaques. These are focal, spherical collections of dilated, tortuous, thickened neuritic processes, which are often centered around an amyloid core. This amyloid core is composed mainly of A-beta amyloid peptides and can be recognized by immunohistochemical stains. Diffuse plaques are also found in Alzheimer's disease, but they're less specific, as they can be found in other diseases as well as even in brains from cognitively normal elderly adults. These vary greatly in size, are ill-defined, and may be identified in what is considered a prefibrillar stage by A-beta antibody immunohistochemistry. Diffuse plaques, although found in Alzheimer's disease, may be present in elderly individuals without visual impairment. They're mainly found in the superficial portions of the cerebral cortex, the basal ganglia, and cerebellar cortex. These are images of amyloid plaques. On H&E staining, plaques can be often seen as ill-defined eosinophilic round or ovoid areas, contrasting with the background texture of the cortical neuropile, as seen in the upper image. With the plaque structure, nuclei of microglial cells and astrocytes can often be seen, often in a radial pattern, which is demonstrated in the lower left image. Finally, a small proportion of plaques are composed of a dense eosinophilic amyloid core without a surrounding zone of altered neuropile. This is seen in the lower right panel. H&E staining is not a real sensitive method for detecting plaques, so we want to use some other fancy stains to better characterize and identify them. And so since the amyloid material is argyrophilic, or can be recognized with silver stains, we use silver stains, and also can use immunohistochemical stains that specifically target the A-beta amyloid protein. So these are some examples of these. In the upper left-hand corner, we see an immunohistochemical stain for A-beta protein, identifying a neural plaque. In the lower left panel, there's a silver stain showing one of these diffuse plaques. In the upper right panel, another silver stain identifying a neuritic type plaque. You can see the core of material surrounded by a little halo and in this zone of staining. And then finally, tau protein can be also identified in neuritic plaques, usually in this kind of punctate pattern in the lower right panel here below. We can also identify neuritic changes in plaques. Usually you need to use an immunohistochemical stain for hyperphosphorylated tau protein. And this image demonstrates these neuritic changes in an otherwise diffuse type plaque. Neurofibrillary tangles are the other histologic hallmark of Alzheimer's disease. Neurofibrillary tangles are tau-containing bundles of filaments in the cytoplasm of the neurons that displace or encircle the nucleus. In pyramidal neurons, they often have an elongated flame shape. In rounder cells, the basket weave of fibers around the nucleus takes on a rounded contour, often referred to as globose tangles. NFTs are not easily found on routine H&E staining. Silver stains or immunohistochemical staining with antibodies to tau protein are necessary for identification. NFTs conform to the shape of the neuronal cytoplasm that they occupy, hence the particular shapes. Those in the cortex are usually flame-shaped or triangular, while those in the subcortical nuclei are typically globose and resemble a ball of yarn. They're commonly found in cortical neurons, especially in the entorhinal cortex, as well as in other sites such as pyramidal cells of the hippocampus, the amygdala, the basal forebrain, and the raphe nuclei. In H&E stained sections, NFTs can sometimes just be seen as faintly basophilic structures within the neuronal cytoplasm, but again, this is not a reliable way to detect them or quantitate them, which is necessary for the diagnosis. Many of them, as they are here, are flame-shaped. With silver staining, you can recognize the characteristic filamentous tangle structure, as such as seen here in a flame-shaped NFT in a pyramidal neuron, which extends into the apical dendrite. Again, this filamentous material is composed of tau protein. The pathologic diagnosis of Alzheimer's disease is made in retrospect. The criteria are based on autopsy studies of patients clinically diagnosed with dementia and compared to age-matched controls with normal cognitive function. Pathologists grade the number and distribution of neuritic plaques and neurofibrillary tangles, and then determine the likelihood that the clinical dementia was due to or not due to Alzheimer's disease. So this determination of the likelihood is based on the fact that the presence of a large number of plaques and tangles has been shown to be highly associated with severe cognitive dysfunction. It's notable that the number of NFTs correlate better with the degree of dementia than does the number of neuritic plaques. So what a pathologist would look for is the presence of neurofibrillary tangles and plaques, as seen in this silver-stained section, and look for these in areas known to be involved by Alzheimer's disease, such as in this case the hippocampus. And so the pathologist would quantitate the number of these tangles, such as here, and the plaques, and come up with a likelihood score for confirming the clinical diagnosis of Alzheimer's disease. In addition to the diagnostic features of plaques and tangles, several other pathologic findings are seen in the setting of Alzheimer's disease. We've already talked about cerebral amyloid angiopathy in the context of brain hemorrhage, but it's almost an invariable accompaniment of Alzheimer's disease. But it can also be found in the brains of individuals without Alzheimer's disease, and is reported to be the second most common cause of primary non-traumatic brain hemorrhage. The most common form of CAA is associated with Alzheimer's disease pathology. Over 90% of patients diagnosed with Alzheimer's disease at autopsy also show CAA. So just as a quick review, in CAA, the media of parenchymal microvessels, especially small arteries and arterioles, is replaced by skeins of thin filaments. These accumulate initially in the basement membrane that surrounds the smooth muscle cells in the tunica media, but then accumulates, leading to the degeneration of the cells and the replacement of the vessels by this homogeneous pink material, which is amyloid. And this can be confirmed with immunohistochemical stains for A-beta peptide. Okay, so here's my game plan summary for Alzheimer's disease. Typically, the brain weight is decreased, although this isn't necessary for diagnosis. Cortical atrophy is most severe in the temporal lobe, followed by frontal and parietal lobes. There's two histological hallmarks of AD: neuritic plaques, which can be demonstrated to be composed of A-beta protein and tau, and neurofibrillary tangles also associated with tau. And then finally, AD is associated with cerebral amyloid angiopathy. Thanks.